Very good morning to all of you, and good afternoon and good evening to all others who are joining from rest part of the world. Today, our guest speaker for the day is Dr. Cedric Hermans from Brussels, Belgium, and he's going to lecture us on living with a hemophilia-free mind, the new ambition of hemophilia care. This webinar is brought to the Mumbai Hematology Group, supported by Novo Nordics, Accurent, Lucien, and Nirvin Life Sciences, and managed by Perfect Square. I thank Team Novo Nordics, Accurent, Lucien, and Nirvin, Mr. Yash, Mr. Kalpesh, and the team Perfect Square, Executive Committee of Mumbai Hematology Group, our chief guest for the day, Dr. Saikat Datta from Bhopal, our guest speaker for the day for Dr. Cedric Hermans from Brussels, Belgium, all our discussants who are themselves very eminent pediatric as well as adult hematologists, and you participants for sparing your Sunday morning, afternoon, or evening from whichever part of the world you're logged in. Let me give a favor for our next weekend activities. Next Saturday, that is 22nd of June 2024, from 7 p.m. Indian Standard Time and 3:30 p.m. Italian Time, we have Dr. Michael Morley from Italy speaking to us on management of vaccinations in NHL patients. And the following day, that is Sunday, 23rd of June 2024, at 11:30 a.m. Indian Standard Time and 8 a.m. Swiss time, we have Dr. Marco Capacci from Pisa speaking to us on frontiers in ITP treatment. Let me introduce our discussions for the day, and here displayed in alphabetical order. To start with, we have Dr. Akanksha Garg from Zydus Hospitals and Zydus Cancer Center, Ahmedabad. Dr. Chandran K. Nair from Malabar Cancer Center, Thalassery, Kerala. Dr. Deepak Charles from Aster Medicity, Kochi. Dr. Govind Patel from Dr. S.N. Medical College, Jodhpur. Dr. Neemia Thanda from North Okkalapa General Hospital, Myanmar. Dr. Jyoti Kotwal from Sir Gangaram Hospital and Gripmark, New Delhi. Dr. Karthik Kumar from AIMS, Rishikesh. Dr. Kunal Chatani from Nagpur. Dr. Lisa Bulsara from Avinash Cancer Clinic, Pune. Dr. Mallikarjun Kalashetty from Manipal Hospital, Bengaluru. Dr. Mopali Ghosh from Institute of Hematology and Transfusion Medicine, Kolkata. Dr. Nisak Thakkar from Wockhardt Hospitals, Rajkot. Dr. Pujita Baireddy from Care Hospitals, Banjara Hills, Hyderabad. Dr. Rizwan Akhtar from SGPJ, Lucknow. Dr. Sandeep Bartake from Bharati Vidyapit Medical College, Pune. Dr. Shailendra Prasad Verma from King's George Medical University, Lucknow. Dr. Shruti Toshniwal Mantri from Shri V Care Clinic, Aurangabad. Dr. Tulika Sheth from AIMS, Delhi. Dr. Yimon Tan from North Okkalapa General and Teaching Hospital, Yangon, Myanmar. Now it's a time to introduce our special guest and chief guest for the day. We have with us Dr. Saikat Datta from Bhopal. Dr. Saikat Datta works as a consultant hemato-oncologist and bone marrow transplant physician at Bansal Hospital, Bhopal. He has over more than 17 years of experience as a clinical hematologist, hemato-oncologist, and BMT physician. He has earned his MBBS degree from RG Kar Medical College, Kolkata, and later went on to pursue MD from NRS Medical College, Kolkata, and subsequently he did his DM in clinical hematology as well. Before beginning his full-time position as a hematologist at Bansal Hospital at Bhopal, he has worked as a trainee at Tata Memorial Hospital in Mumbai in the field of bone marrow transplants in the year 2021. It's my privilege to welcome Dr. Saikat Datta to inaugurate our webinar and give some words of wisdom. Over to you, Dr. Saikat Datta.
Yeah, thank you, Dr. Amit Khurana, for this kind introduction. Good morning, all and one. And at the outset, I would like to thank Mumbai Hematology Group and especially Professor M.B. Agarwal for this opportunity. It's a great privilege. And I would like to congratulate Mumbai Hematology Group for this excellent webinar and CMEs in hematology, which are pretty exciting. And we are learning a lot from these sessions. So I've been told to say some word of encouragement for young hematologist and young hematology trainee. So for my opinion, hematology is the most advanced and most exciting branch of medicine. And nowadays we have lot of new therapeutic modalities in our hand with which we can keep our patient live long and long, and we can make them to run a healthy and productive life. Once upon a time, hematological malignancy was incurable and deadly. we don't have much. For other malignancies, we have surgeries, but liquidity of blood prevented us from having surgery, so it was deemed incurable. Then there were chemotherapies along with side effects of chemotherapy. Then there had been some immunotherapy, and nowadays we have lot of targeted therapy and small molecule inhibitor. With these newer therapies, newer diagnostic modalities, and better understanding of disease biology, good supportive care, we can treat our patient in a better way. We can take out any cell from blood, we can analyze them, we can find target, and we can make newer targeted molecules for virtually any and every diseases. Once liquidity of blood was inhibitor and impediment for therapy, now we can take T cell, we can engineer them, and we can make them to act against patient malignant cell after infusion. We can take out patient stem cell, we can edit them, and after killing the rest of abnormal stem cell, we can infuse, and that is called gene therapy. So we are in a exciting stage of hematology, exciting time in hematology, and the next decade would be more exciting, as I think. With this, I would like to end here, stop here, and request Dr. Khurana to take us to the next main session, for which we are eagerly waiting for. Thank you.
Thank you, Dr. Psychiatrist, for that kind words of wisdom. This will really help our young budding hematologists for sharpening their future career. Thank you so much for being with us as our chief guest today. Let me share the screen again. Now it's a time to introduce our guest speaker for the day. We have with us Dr. Cedric Hermans from Brussels, Belgium. Dr. Cedric Hermans currently heads the Division of Hematology, the Hemostasis and Thrombosis Unit, as well as the Hemophilia Center at St. Luke University Hospital in Brussels, Belgium. He was appointed Associate Professor at the Medical School of the Catholic University of Leuven in 2003, Full Professor in 2012, and Vice Dean in 2015. Professor Hermans has co-authored more than 275 original articles in international journals with H-index of 41 and is a member of several scientific societies and international advisory boards and collaborative research projects. He was the president of EAHAD and is currently the member of the board of directors of the World Federation of Hemophilia and the editor-in-chief of the Hemophilia Journal. His main research interests lie in hemostasis and thrombosis, especially clinical studies of the treatment modalities and the wide spectrum of complications of hemophilia in both developed as well as developing countries, as well as new anticoagulants and management of thrombosis. And today he's with us and is going to lecture us on living with hemophilia-free mind, the new ambition of hemophilia care. Well, thank you so much. Over to you, Professor.
Thank you. Thank you very much. Thank you for the invitation and this opportunity. So I will start sharing my slides. So can you see my slides?
Yes, sir, absolutely. Please go ahead.
Thank you. So it's a great pleasure to address with you this new ambition in hemophilia care with a quite provocative title, Living with Hemophilia-Free Mind, the new ambition of hemophilia care. So these are my disclosures that are mainly related to interactions with the pharma industry involved in the field of hemophilia. I'm also, as you said, editor-in-chief of the Hemophilia Journal and a medical member of the board of the World Federation of Hemophilia. So I'm sure that you're all familiar with hemophilia, which is an inherited clotting factor deficiency resulting from the total or partial absence of factor VIII, factor IX. Factor VIII for hemophilia A, factor IX for hemophilia B. But as you know, this is a quite heterogeneous disease, and hemophilia is typically classified according to the level of factor VIII, factor IX that can be measured in the blood. Some patients have a complete total absence of this clotting factor. They are referred to as severe patients. Some have moderate or mild deficiency. And as a result of this clotting factors deficiency, mainly patients with severe, but also some patients with moderate hemophilia do present with spontaneous bleeding complication that can that mainly affect the musculoskeletal system. So the main clinical sign is, as you know, hemarthrosis, muscular hematoma, but these patients are also at risk of developing life-threatening bleeds, such as intracranial bleeds. So although hemophilia is a blood coagulation disorders, well, clearly most of the complication, in fact, deal with the musculoskeletal system. But hemophilia is much more than bleeds. Yes, if we think about bleeds, yes, you have the joint bleeds, the muscle bleeds, some life-threatening bleeds. Patients also present very likely with subclinical bleeds, so small bleeds that you do not see clinically, but that can damage the joints in the long term. As a consequence of this bleed, patients will develop pain, painful symptoms. They will develop arthropathy, chronic arthropathy that can be highly disabling, leading to functional impairment, and many patients might require orthopedic surgery. This arthropathy is also responsible for limitation in physical activities and sportive activities. Hemophilia, if not treated, also has a major impact on school attendance, work productivity, career choice, and can be associated with a major financial burden if treated, but also if not treated. So in my view, the treatment of hemophilia should be considered as an investment. If you don't pay for the treatment, you will have to pay for the consequences. And hemophilia also has multiple psychological consequences, family impact, and also does impact on mental health of our patients. So clearly, when considering hemophilia, you should not exclusively focus on the bleeding manifestation. Clearly, that disease has multiple impacts. What are the current ambitions of hemophilia therapy? Well, the first one is certainly to prevent the joints. The joints bleeds, and this is achievable, but the only way to do that is to provide patients with what we call preventive treatment or prophylaxis that should be personalized, that should ideally be initiated very early in life, but it's never too late to start prophylaxis. And prophylaxis has classically used clotting factor concentrate, but no, we have alternative treatments. I'll come back to that. The objective of the treatment is probably not only to avoid clinical bleeds, but also to protect the joints completely by avoiding the occurrence of microbleeds, the small bleeds, the subclinical bleeds that we do not see. But this is an open question. We do not know for the moment whether all the treatments that we have, and I'll come back to that, are able to achieve this. Zero infection, yes, this is currently achievable with the current plasma-derived or recombinant concentrate. You know that in the past, well, in some parts of the world, patients with hemophilia were massively contaminated with HIV and HCV. If we use the current treatments available, especially the safest plasma-derived concentrate and all the other options that are now produced by biotechnology, well, clearly our patients are safely treated. There is another major complication of hemophilia, which is the development of neutralizing antibodies against the clotting factor that these patients do not produce. This is certainly true for our patients with hemophilia A, the severe ones who do not produce at all factor VIII. And we know that once you started treating this patient, when they are started on a preventive treatment or when they receive factor VIII, many of them will develop antibodies against the exogenous factor VIII that will complicate the treatment. So for the moment, honestly, there is no option to prevent this complication. It seems to be inevitable. When you treat patients with factor VIII, some of them will develop antibodies. The good news is that we now have much better treatment to support hemostasis when these patients do develop antibodies, and we also have good treatment protocols to eradicate these antibodies, but which do work in many patients, but not all of them. So what is the goal of the hemophilia treatment? So for a long time, especially I will focus on a patient with severe disease who do not have clotting factor VIII or factor IX. So the goal over the last decades has been to convert this patient from severe into moderate, because we know that patients with moderate hemophilia, I mean patients who have levels slightly above 2-3%, do bleed much less. And this is something that has been promoted using plasma-derived factor VIII and also the factor VIII, factor IX produced by biotechnology with a short half-life. That was possible. But now we have multiple new treatment options, and these new treatment options can be much more ambitious. With the new treatment option, it's possible to convert the severe patient into mild patient. Mild patients being patients who have more than 5%. And even with some treatment options, it's even possible to normalize coagulation, something that was totally unthinkable several years ago. So we now have some patients with hemophilia, severe hemophilia, who can have a nearly normal or even totally normalized hemostasis. And this is achievable with some of the new treatment options. And clearly, the goals of hemophilia therapies have changed dramatically over the last decades from saving life to normalizing life. If there is no treatment available, well, very likely the patient will develop severe arthropathy early in life and could even die because of life-threatening bleed, intracranial bleed, for instance. So clearly, if you live in a country and a region where very limited treatment is available, so the purpose of the treatment will be to treat this massive bleed or life-threatening bleed or avoid them. But if you have access to better treatment, what can you do? Well, you can be much more ambitious. By prophylaxis, it's possible to avoid spontaneous bleed, even traumatic bleed for patients who are physically active. And this is the purpose of my talk today. If we are able to normalize hemostasis, well, it's very likely that our patients will have a normal life, not only physically, but also mentally, considering the multiple implications of the disease. This busy slide shows you the multiple treatment option of hemophilia. Well, clearly hematology is witnessing major advances, therapeutic advances, and this is also true for hemophilia. Well, if you move from the left to the right of my slide, so on the left you can see the classical replacement therapy. So these are concentrate of factor VIII, factor IX, produced from plasma or produced by biotechnology. And biotechnology made it possible to extend the half-life of this clotting factor concentrate, but this is what we call replacement therapy. Factor VIII, factor IX is missing, and you replace factor VIII, factor IX. And this is given intravenously. We also have multiple what we call non-replacement therapy. So these are other strategies that will compensate for the clotting factor deficiency using alternative strategies. One is a bispecific antibody, emicizumab, Hemlibra, that mimics the action of factor VIII in the blood. This is an antibody. It can be given subcut infrequently, and it will maintain a constant hemostatic activity. And we also have multiple what we call non-factor therapies that rebalance coagulation. Some of them are now commercially available, but most are still in clinical trials. So the strategy here is different. Instead of replacing factor VIII, factor IX that are difficult to replace, is to rebalance the coagulation. So how could I explain this? Well, sort of inducing thrombophilia in a patient with hemophilia just to compensate, because we know that blood coagulation is a delicate balance. All these treatments have in common to be given subcut. And another treatment option is gene therapy. It's possible to perform gene therapy, and I'm aware of several gene therapy trials going on in India, for instance. And clearly here, the ambition is different, is to induce endogenous productions of factor VIII, factor IX following a unique intravenous infusion of the vector. So multiple treatment options. So clearly we now live in a totally new hemophilia environment with new treatment modalities, many of them. Well, depending on the place where you live and the money that is invested in hemophilia treatment, clearly not all these treatment options are available. Another one is prophylaxis for all. So it's clear that in 2024, all or severe patients should be on prophylaxis, I mean preventive treatment. And the ambition is to have zero bleeds. So if the patient has hemophilia, you should do everything possible to provide these patients with treatment that will provide a constant hemostatic activity and prevent the bleeds. And clearly we have new treatment options. Well, they've evolved a lot over the last decades, but and I'll come back to that slide. What we try to do now is to provide our patients with the best quality of life and ideally normalize their hemostasis. So that brings me to this concept of being hemophilia free mind. So if you think about hemophilia, well, hemophilia clearly has physical consequences: joint bleeds, muscle bleeds, arthropathy, functional limitation if the disease is not well controlled, leading to disability. And also you have all this burden of repeated infusion, IV, and for the lucky patient, we have access to the most recent treatment, subcut. But that disease is also responsible for multiple mental effects. You can imagine, and for those of you who follow patients with hemophilia, a lot of pain, fear, depression, frustration, because of all the limitation imposed by the disease. But clearly, you cannot separate the physical from the mental implication. And if you look at some philosophical perspective about this, well, a long time ago, Plato in Greece, old Greece, described that the mind and the body are two distinct entities with different nature and functions. More recently, in France, Descartes said that mind and body are distinct and separable dualism, so completely separated. And you need to go to Spinoza, more or less at the same period. And Spinoza wrote, it's quite difficult to understand what Spinoza wrote, but I'm not a philosopher myself, but what he said is that man is defined as the union of two modes, a body and a soul. This is a human identity. And I think these concepts are important to better understand the multiple implications of hemophilia and what the new treatments can really offer. Because clearly, if you think about the consequence of hemophilia, the mental consequences, I mean fear, pain, depression, frustration, are clearly linked to the physical consequences of the disease. So that it's very clear to me that if you are able to improve the physical status situation of the patients, that will have major positive mental impacts. And what are the current expectations and aspirations of patients with hemophilia? They are listed on this slide. Well, what do patients expect? Well, in blue, they expect to have access to treatment that is safe, that they can trust, that is not longer associated with the risk of contamination. These patients certainly do not want to experience bleed, and these bleeds might be spontaneous bleed, post-traumatic bleeds, and even subclinical bleeds. So this is what our patients expect physically. But what do they expect mentally? Well, they expect to have no pain today and tomorrow. They want to experience a treatment with a minimal burden, or ideally no burden at all. They want to have a life without major restrictions, ideally no restrictions related specifically to hemophilia. And also, they expect to have a minimal or mental burden imposed to them by the disease and its treatment. So clearly, these are the new ambitions of hemophilia treatment, and this is more or less aspirational. Let's be honest, not all the patients on this planet can achieve this, considering that many patients with hemophilia are not yet diagnosed and that many do not have access to treatment. But I think that should drive our hemophilia practice and our ambition. So clearly, prevention of bleeds for all patients with a severe bleeding phenotype. This is the first objective. The second one is to achieve zero spontaneous bleeds. So these patients should be bleed-free. We also expect minimal treatment burden. And if we can achieve this, well, this should liberate our patients physically, but also mentally, leading to the concept of being hemophilia free mind, liberated. So that brings me to the concept of being hemophilia-free mind. An original one that is receiving more and more attentions in the community. What does that mean? Well, this concept refers to the liberation of patients with hemophilia, physical and mental liberation. So this concept was initially launched by my team a few years ago. So on the top left of the slide, so you can see one of the first paper that we produced, Living with a Hemophilia-Free Mind, the new ambition of hemophilia care. The first author is one of my PhD students, Evelyn Crump. And we published this, and that paper was really well received. And more recently, I produced two other papers on this. Well, not all of them are on this slide. One with the title of Towards Achieving an Hemophilia-Free Mind with the new treatment options that we have. And at the bottom right, this is a more recent paper evaluating or describing the impact the therapeutic revolution of all these hemophilia therapies could have, not only in male patients, but also on women and girls. Because as you know, women and girls are also concerned by hemophilia. hemophilia is an X-linked disease, and some of these women and girls also suffer from hemophilia because of unbalanced inactivation of the X chromosome. So it's not impossible to have women and girls with hemophilia, and there is no reason why they should not benefit from this new concept. So clearly, we live in a new era with new expected freedoms for our patients with hemophilia. So this is part of the paper that I produced with Glenn Pierce, with medical vice president of the World Federation of Hemophilia. So clearly, the first objective is to be bleed-free. That means a freedom from joint and muscle bleeding, provoked or spontaneous, clinically evident or subclinical. If the patients do not bleed, they will be arthropathy-free. So this is the freedom of not developing joint damage and disabling arthropathy. If you do not have arthropathy, you will not experience pain, which is very important. Painful symptoms are a major problem in our patients with hemophilia who have not been well treated. And if the treatment is associated with a minimal burden, if you can avoid the multiple repeated painful injections, especially if they are given IV, well, that will also minimize the burden. If we can achieve all this, the patients will be what we call hemophilia mind-free, and that refers to the concept of being free or liberated partially or ideally totally. And the brain, the mind, the consciousness will be liberated from the constraints, the fears, the restriction of hemophilia and its treatment. Let's be honest, that remains an aspirational concept. It's not yet possible to achieve this in all our patients because of multiple factors, but clearly this is an aspiration. In the past, the aspiration was to have all our patients on prophylaxis. The aspiration was to avoid the bleeds, and now we can expect to reach this new condition, which is an aspiration for patients with hemophilia to have one day, 2 days, more and more days without hemophilia on their minds and considering them as bleeders. So this concept is the absence of psychological burden and of permanent thoughts about the disease and its complication among patients with hemophilia. And clearly, when I talk to my patient, and this is how I got this idea, when you talk to your patient who has no access to this treatment, this new treatment, I mean the new bispecific antibodies, gene therapy, treatments like that, well, clearly, some patients report having hemophilia-free days. So these are days where they do not think or have to think about hemophilia and its consequences. And this is true, as I said, for some of the long-acting factor concentrate emicizumab gene therapy. And in my view, this sort of ambition should be promoted. And if we look back in the history of hemophilia, until 2010, the focus was on preventing damage to the body. Clearly, hemophilia is a bleeding disorder leading to arthropathy. And we wanted to avoid this bleeding complication. So initially, patients received factor VIII, factor IX from plasma. But as you know, as a result of this, many patients got contaminated with HIV, HCV. So the focus was on the development of treatment devoid of infectious risk, so not damage the body by infection. Prophylaxis then became available. So this is regular treatment, ideally provided at home. And clearly the purpose of this is to prevent joint bleeds, intracranial bleed, perioperative bleed. So clearly the focus is on the physical consequences of hemophilia. And that was the priority until not so long ago. Now we have new treatments that are illustrated on this slide. So in the 70s, 80s, 90s, plasma-derived factor VIII, factor IX from plasma and then produced by biotechnology in the 90s. And more recently, a bispecific antibody has been developed, extensively validated. Its name is emicizumab, and it's really an excellent treatment alternative for patients with severe hemophilia A. These patients will receive subcut injection once every week, 2 weeks, 4 weeks, and have a constant correction of their coagulation, and gene therapy is another option. So clearly all these treatments have in common to be less burdensome, to provide better protection, and to provide constant and stable protections over time. More recently, the assessment of the quality of life came into play and received more and more attention. So this is another way to look at the consequence of hemophilia on our patient. And if you look at this, there have been many, many publications about the quality of life, more than 1,500 over the last decades. And all these studies, they have tried to explore and have clearly demonstrated a significant improvement in health-related quality of life with in our patient using different tools, different questionnaires that are still evolving, because it's not that easy to capture by all these questionnaire the impact of all the treatment on our patient, especially considering that several dimensions have to be assessed. And let's be honest, this quality of life questionnaire, they are useful, but they are time consuming. If you ask your patients too many times to complete them, they will not be that happy. And all of them have their own strengths and limitations. Today, the priority should likely be being hemophilia-free mind, as illustrated on this slide. And again, to show you what we try to achieve, being bleeding-free, arthropathy-free, pain-free, and burden-free. So this is part of the publication I recently produced with my colleague and friend, Glenn Pierce. And what we try to show on this visual is that if you want to reach the status of being hemophilia liberated, you really need to be able to provide patients with treatment that prevent all the bleeds, that prevent the development of arthropathy, that have a minimal burden, so that the patients do not experience pain. So clearly, this is a complex equation, and if you want to make this equation possible, you need to fulfill all these conditions, I would say. So let's put this a little bit graphically and visually. So let's try to dive into the mental ecosystem of our patients. So what do our patients expect from the treatment? Well, first of all, our patients in hemophilia have this constant fear of bleed. So clearly, we need to work on this. Make sure that we prevent the bleeds. The second one is the pain, as I said. The medication is important. It depends on the type of medication that you receive. It's clear that if you have to take the medications every day, and if the medication is given IV, well, clearly that will be part of your daily concern. So we need to work on this. The treatment efficacy. So it's clear that not all the treatment work in the same way. So if you think about clotting factor 8, factor 9 deficiency, the concentrate that we have used for many, many decades are treatment that are highly fluctuant with peaks and troughs. So that means that the patients have to integrate this in their daily life, and being at the peak or at the trough will have a major impact on their bleeding phenotype. The injection schedule, so that could also be a major concern. So you need to think about this every day. So if you have a treatment with less burden that can be given infrequently, that will help you. How you can be engaged in physical activity, and that will certainly depend on what I just listed on the right part of my slide. Blood-borne infection, it's clear that patients who were infected by the hepatitis C virus or HIV still have this major concern on top of their brain every day. The impact of hemophilia on employment, education is important. And since this is a genetic disease, and if you are a male with hemophilia, if you have daughters, they are carriers. You might have brothers with hemophilia, your mother could be a carrier. So clearly the impact on the family is important. And we also know that for the partners of patients with hemophilia do play a major role in the management, but also the acceptation of the disease. So that disease has a major impact, as well as traveling. If you have hemophilia, it could impact on your ability to travel. So clearly, you can easily imagine looking at this, that if you have hemophilia, your brain will be constantly occupied by hemophilia, its treatment, and its implication. So this is where this new status came from. So, and again, was more or less but more redundant with what I already said. So with this new status, you expect to liberate the brain, the mind, the consciousness of all these aspects that I just reviewed with you. So that would be being hemophilia mind-free. And clearly more and more patients can experience this. Not all the time. Sometimes it could be 1 day, 2 days, 1 week, one more, depending on the treatment modality. And clearly the new treatment have this potential. So this is the concept of being hemophilia-free mind that does integrate the multidimensional impact of hemophilia on the mind. And honestly, what I increasingly do in my clinic, I ask my patients, do you currently experience days when your mind is not busy, occupied by hemophilia? And if the patient tells you yes, well, I try to quantify this. And I have some patients who tell me, well, doctor, with the new treatment, honestly, the last time I had to think about hemophilia is when I had my last injection of a subcut treatment, and that was 3 weeks ago. Since then, well, I could have a normal life from the morning until the evening with no impact on my daily life. And I think this is really what you expect from the new treatment. But is this achievable? So if you think about the treatment that we have used for several decades, the short-acting factor VIII, factor IX, honestly, they do not allow this liberation. If you are on short-acting factor VIII, factor IX, yes, your hemophilia will be treated. You will be on prophylaxis and probably will bleed less. But at the same time, the burden on the brain will be massive, just because of the properties of this treatment that need to be given frequently, that do not result in a constant protection with peaks and troughs. Also because the patient has to be highly compliant. So clearly the injection schedule is very important. And although this treatment works, they do not provide full protection. We know that many patients with hemophilia still bleed, even if they are on prophylaxis with this short-acting factor VIII, factor IX concentrate. So clearly this concept is highly dependent on the treatment modality. If we now think about the non-factor replacement therapies, they will have a positive impact. So why? Because they are more efficient, they need to be given less frequently, patient will have constant hemostatic activity, so there will be some liberation. And this liberation is illustrated on my slide. Instead of having a mind completely occupied, busy by hemophilia, well, it will become a little bit green or yellow. So that was a way for us to illustrate how the mind of our patients could be to some extent liberated. And with gene therapy, it could be even better, at least for the patient who has a good response to gene therapy. But clearly, gene therapy will not solve all the problems. And I'll come back to that. If you have severe arthropathy, if you had hepatitis C in the past, gene therapy will not correct this. So this is important to know. So clearly with the new treatment options from plasma-derived factor VIII to recombinant to long-acting to emicizumab to gene therapy, clearly what do we see? Clearly we see a major improvement of the management of the disease in terms of less bleed, better quality of life, but we also witness this major mental liberation of our patient, major impact on their quality of life. And this is a slide I showed you at the beginning. This is a very nice slide that was prepared and published by Mark Skinner, past president of the World Federation of Hemophilia. And he nicely illustrates the fact that what we have been able to achieve in the field of hemophilia with the new treatment is something that was not imaginable in the past. So in the past, the focus was just on improving survival, trying to protect the joints as much as we could. And now, if you move from the bottom of the staircase to the top, well, clearly everything is improving, not only physically, but also mentally. And we also provide our patients with more and more freedom. And it's clear that if you are at the top here, well, if your level of coagulation is normalized, well, you could have a very good, if not excellent, quality of life. And so clearly there is a excellent parallelism between, this functional cure and also this concept of achieving health equity in our community. So clearly with our concept of being hemophilia mind-free is just a reflection of this. This small is the same concept. If you improve care, if you protect our patient, if you provide them with better treatment, there will be a major mental liberation. And this mental liberation will, in my view, be nearly complete total if coagulation is normalized. But let's be honest, that depends also on each patient profile. If you take the example of an adult patient born in 1989, well, clearly this patient here in my country, but I'm sure in your country, this patient has had some sort of hemophilia full mind across his life. All his life, hemophilia has been there because of the treatment, the burden, the consequences. So it could be difficult to liberate this kind of patient. If you take someone born much more recently who has had access to the new treatment, well, clearly, as you can see here, if these patients can have access to the new treatment, you will probably be able to liberate him from the burden of hemophilia, not only physically, but also mentally. So that will have a major impact on his mental ecosystem. And clearly, what we expect for the future, and this is very important for all the newborns with hemophilia that will be diagnosed in the future, let's hope that they will have access to the best treatment so that they will not develop all the consequences of hemophilia. And the purpose of the treatment of the future would be to maintain a hemophilia-free mind in this patient. So that would be different from this one, which is a liberation, and this one who would keep some sort of hemophilia full mind status. For those of you who have had the opportunity to give access to innovative treatment to our patient, I think we need to interpret the benefit of this treatment with a little bit of caution. So what happens, and I'm sure it will be the same in your country, your patients will have more and more access to innovative treatment. So they will be switched from the classical treatment, IV treatment, to the new treatment. The new treatment are in the middle of my slide. And when they are switched from the old treatment to the new treatment, there is some sort of honeymoon. What does that mean? Well, that this patient will experience much less burden. They will not longer bleed. They will have less pain, less limitation, more freedom. But let's be honest. The new treatments that we have, especially when we give them to older patients with multiple problems, joint problem, well, clearly that will not solve this. So the new treatment options do not repair, compensate, abolish, dissipate all the consequences that hemophilia caused in the past. So this is important. I have many patients. Some of them were treated with gene therapy. So today they don't have to treat themselves with factor 8, factor 9. So this is excellent. But at the same time, they still have limitation, physical limitation or frustration, because clearly the consequences of hemophilia are still there. And this is important to be aware of. So we should not be over optimistic, and we need to tell our patients that clearly this treatment will help them from a hemostatic point of view, but these are not treatments that are able to correct all the consequences of hemophilia. This concept is also true for women and girls with hemophilia and their relatives. So this is, I think, a very important concept that is part of that paper that I already shared with you, the under-evaluated impacts of the therapeutic revolution of hemophilia on women and girls. So what is this? Well, clearly, if male patients with hemophilia have access to new treatment, that will have multiple indirect and collateral benefits on the entire family. That will result in the liberation of the patient, as I already said. So, but this is also true for the mothers. Let's say you have a mother with a young boy with hemophilia. It's clear that her life as a mother will completely change if her son has access to the best treatment. So she will have more freedom herself. She will not longer live with this constant fear of hemorrhagic accident for her son. Maybe she will become much less overprotective, because this is something that we often witness in mothers of young boys with hemophilia. There will be less disruption on her own social, professional, personal life. And also many mothers feel a bit guilty of having passed the disease to their son, and that could alleviate this. And we also know, and I've seen this, that better treatment of hemophilia have also a major impact on the entire family. I mean, the partner, I mean the colleagues at work, the friends, because the patient will experience all these mental benefits that I summarized with you. So this is something we put together. As you know, visual abstracts are increasingly important. And if you look at the family tree, the new treatment of male patients will impact a lot on women and girls of hemophilia, the ones who have a bleeding tendency, but also on the partner, the other member of the family. So this is quite important, but this is also something that has never been really valued in the clinical trials. These are dimensions that we do not really pay attention to, although they have a significant impact on patients' life. So clearly, for hemophilia treaters, caregivers, and patients, these new therapies of hemophilia have the potential to liberate patients from the mental burden of hemophilia and give them the opportunity for real physical, social, and mental fulfillment. So this is important. And the World Federation of Hemophilia decided to integrate this concept in a new tool that has been recently developed, which is the WFH shared decision-making tool. So this concept is receiving more and more attention. But let's be honest, this concept has multiple limitations because it's currently impossible to completely liberate the mind of our patient. Our patients will still need follow-up. And our patients, for instance, who had gene therapy or have access to new treatments, as I said, still have arthropathy. If they had arthropathy before, they will keep this arthropathy. You cannot change the hereditary nature of the hemophilia. So hemophilia still has an impact on family planning, carrier screening. This is important. There are some effects of these new treatments that we do not know about. This is important. And also very important, many new treatments, they do improve coagulation, but do not fully correct coagulation. So that means that patients will still need replacement therapy if they undergo invasive procedure surgery, for instance. So clearly, and this is a limitation of this concept, and I will go through the statements quickly. The new treatments, despite their advantages, do not dissipate the musculoskeletal sequelae and the multiple, possibly irreversible social, family, professional, and educational frustration or deprivation attributable to hemophilia, as well as the burden of transmitting genetically a disease with serious consequences. So that has limitations. Also, this concept has a lot of impact on the care of patients with hemophilia, and I think this is important because we know, I am sure this is the same in your country, multidisciplinary care of hemophilia is important and I think remains important. Why? Even if we have multiple new treatment options and if the management of hemophilia has been facilitated and even if the ambition are totally different, well, clearly we still need a very good multidisciplinary team to make the patients familiar with this new treatment option, implement them, and also our patients might have multiple consequences of hemophilia, physical, mental. So we need to make sure that the whole team is there. And I think the entire team is there to help them achieve this hemophilia-free mind. This hemophilia-free mind does not fully or completely rely on just change of treatment. Let's say if the patient has a severe arthropathy and needs surgery, well, clearly surgery or knee replacement, for instance, could be very important to relieve this burden of hemophilia. So orthopedic surgeon, psychologist, nurse, all these people are quite important. So it's important to promote this concept in the community. It also requires a very important trust between the doctor and the patient. This concept is also could be difficult for some colleagues to implement this in this practice, because that means that during your clinic, you not only focus on the physical consequence of the disease, but you also try to dive into their mental ecosystem. Some doctors like doing this. Some doctors do not like doing this. They say it's not their job. Well, personally, I think this is very important. But what we should try to do is to develop tools in the future that will help us more objectively assess the mental burden and the liberation that is provided by the new treatment. And there is something I would like to emphasize with you, is that this concept is, in my view, applicable to many diseases and many new treatments. And I think this is not only true for hemophilia, it could be true for many other rare disease, hereditary disease, genetic disease, but also in your field of oncohematology, there are many patients who cannot be liberated to some extent of the burden of their disease just because multiple treatment options are available. And let's think about gene therapy for sickle cell, thalassemia, also CAR T cells, multiple. And I think this is a new dimension. And I think we should increasingly pay attention to that. I think it would be a nice concept to test in other therapeutic areas. And let's be honest, I'm quite lucky. I live in an area in Europe where access to care is more or less easy, but it's not true for most of the patients. We know that 85% of the patients globally do not have access to treatment. So it could be a little bit frustrating to hear about this concept of mental liberation when you don't have access to treatment at all. At the same time, I think we should value this as an aspiration for the global hemophilia community. So to conclude, I hope I could convince you that beyond their physical benefits, the new treatment of hemophilia allow patients to be mentally liberated from the burden of hemophilia to some extent, not all of them, but I think this is something that is possible. And living without having to constantly focus one's mind on the treatment of hemophilia and its hemorrhagic complication is now a reality for an increasing number of patients. Important to stress this. This concept, in my view, does not exclusively apply to male, but also to women and girls with hemophilia, as well as their relatives. This is important. And I think this is also applicable to other disease. If you have a patient with multiple myeloma who has access to a new treatment, and is liberated also mentally, not only physically, well, clearly the whole family will benefit from this. But the nature of this liberation and its extent are unique to each patient, so that every patient will experience this in a different way, considering his own status. And I think that better understanding this concept, trying to quantify it, that will be difficult, and trying to monitor it represent significant challenges, not only for hemophilia, but also for other disease. So I'll stop here and thank you for your attention.
Thank you, Professor Hermans, for that wonderful and beautiful talk. It was just mesmerizing and wonderful to hear about the hemophilia-free mind, actually. Really, it helps us, both should be the correct treatment, both on the mental side as well as the physical side. Absolutely true, sir. So I now request all our discussants to please put the raise hand sign so that we can start our question answer session with Professor Hermans.
If you agree with me, because this is a new concept, aspirational
Absolutely.
concept. So, and as I said, because I think many of our colleagues here work in the field of oncohematology or oncology, I think, or other rare disease, I think this concept could be applied in other disease areas.
True, sir.
So,
absolutely. That was really beautiful. So, Dr. S.P. Verma, you have a question?
Yeah, hello.
Yeah, please go ahead, Dr. Verma.
Yeah, so it was a beautiful talk. I just wanted to know, like, whatever treatment modalities are available as of now for hemophilia, which treatment modality do you think is going to, affect this hemophilia-free mind most? Is it imicizumab for hemophilia A, or is it the gene therapy? Because we know that gene therapy is not going to be available for most of our patients in the recent times and the times to come. So what treatment modality will be affecting this entity, hemophilia-free mind, the most?
well, in my view, certainly for hemophilia A, the bispecific antibody, emicizumab, Hemlibra, is one. But as you know, there are no new bispecific antibodies that are currently being developed, more potent, so with a better correction of coagulation, so that would even better protect the patient. Gene therapy, well, probably for hemophilia B, we know that for hemophilia A, it's a bit more challenging because the variability and the duration of the response. But I think gene therapy for hemophilia B seems to be really promising. And then let's not forget, this multiple rebalancing agents like, fitusiran, that agents that reduce antithrombin. Although I would like to see data outside clinical trials, whether making sure that these treatments are completely safe, because these patients will have some thrombophilia. And also, let's not forget, we also have now this ultra long factor VIII. So this factor VIII, which is not longer, which does not longer bind to endogenous von Neumann factor. So that one also could be an option. It will require 1 weekly infusion, but if you accept that one, Altuvio, and Altuvio, that means you inject yourself and then you have 7 days. Your hemophilia is corrected, so you have a burden once a week. Now I think we have plenty of treatment, and I think that more and more we'll have treatment that will normalize coagulation and that will facilitate this.
Thank you. So as you talked about quality of life assessment tools, there are so many tools. Are you also devising or working on this hemophilia-free mind? Any tools or any anything to measure that?
Well, for the moment, we just ask the patient, how many days per week are you mentally liberated? So that means you don't think about this. But I'm working on this because this is something a little bit subjective. So we are working on this to develop tools that would evaluate the impact on the new treatment on, physically, mentally, but this is quite complex. But we are working on this. But just ask your patient, when did you last think about hemophilia? If your patient tells you, I last think about my hemophilia 15 days ago, I think that means he had 15 days where he was free. And this is very simple.
Thank you.
But it's also subjective because some patients, they accept some consequence of hemophilia. Let's say they have some limitations, and some will accept this. Some will not accept. So it's highly individual. But I think it's important to know. But if someone accepts some of the limitation because he could work on this, you might have patients with hemophilia, they wanted to work in the army or be a policeman or whatever, and they couldn't do it. So it could be a frustration for them. So some of them will be frustrated all their life, and some will accept this. If you do not accept this, I think you will never be hemophilia-free mind. If you accept this because you get the support, you could be liberated. Yeah.
Thank you, Dr. S.P. Verma. So there are some questions from the audience. Dr. Yimon Tent wants to know about your experience of managing pseudotumor in hemophilia and factor replacement regimen in major surgery, as well as disarticulation.
Well, pseudotumor, here in my country, we don't see pseudotumor any longer. Pseudotumor means that the patients develop a muscular hematoma that grow with time. So ideally, these patients should be on prophylaxis and they should be on operation if it's possible to operate them. But what I would try to do is to have them on treatment to at least allow better control of that pseudotumor. And surgery and disarticulation, what you need to do for the moment, you need to give these patients concentrate of factor VIII and have a factor VIII which is certainly above 50%, 60%, depending on the resource that you have, and make sure that you have enough treatment to cover the entire post-operative period. So please make sure that in advance, you make sure that you have enough treatment, because do not initiate this kind of surgery, which can be, which can result in major bleeding complications if you don't have enough treatment.
True, sir. Thank you so much, sir. Dr. Upase has a question. Did any experience with inhibitor development with emicizumab therapy?
Well, there have been a few cases of very few on this planet of patients who developed antibodies against the antibody. So these are anti-drug antibodies, very rare, but still you need to make sure that the patients do not develop that. But this is really, really unusual. Very, very unusual. Honestly, that should not refrain you from using that drug.
Thank you, sir. And the question from Dr. Saikat Datta, how to plan major surgery when the patient is on Hemlibra?
Well, not difficult. You should give him factor VIII as you would do. So Hemlibra, patients on Hemlibra, they have equivalent factor VIII around 10-15%. So you should just add factor VIII to that Hemlibra to make sure that the patients will reach 50, 70, 80%, depending on the surgery. The difficulty is that you should work with the lab and make sure that you can measure this exogenous factor that you give. You need specific assays to do that. But if you don't have access to this assay, please treat your patient with factor VIII as you would do if the patient was not on Hemlibra. What will be much easier is that you will have to treat your patients intensively during a few days, and then for the post-op and rehabilitation, the patients will be covered by Hemlibra.
Thank you, sir. Another question from Dr. Babita Sodi. She says that hemophilia-free mind is an absolute and artistic frame of mind. Her query is, out of this, which therapy is within reach of patients? Say, if developed countries or developing countries like in India, where everything is from patient's pocket, say gene therapy is beyond out of reach for many of our patients.
I know, as I said in my talk, that could be a little bit frustrating to listen to this kind of, I agree, but I think that things are globally changing. It takes time, but if we do not have ambitions and aspirations, things will never change. So clearly, if I had to give a talk 20 years ago, I would have talked about prophylaxis with factor VIII. That was not very common. We see that prophylaxis is more and more common. So things are changing, but it takes time. But what we need to do is to convince the payers that they need to invest a bit in hemophilia. If you don't pay for hemophilia, you will have to pay for the consequences of untreated hemophilia. So I agree. This is just also to show what can be achieved today. But I agree. I'm active in the World Federation. I know the disparity of access to care on this planet. This is something not acceptable. But I hope that this kind of aspiration could help people promote treatment for their patient, because it's possible not only to control the disease, but also to liberate our patients mentally. Yeah.
Thank you, sir. Thanks a lot for that. Any discussions? Want to ask any other question? Well, so there are no more raising signs and no more questions from the audience. Well, thank you so much for that, sir. Fantastic and lovely talk. It was a real honor for all of us to think in the two minds. One is the bodily mind as well as the mental mind in hemophilia. Thank you so much for that wonderful and lovely lecture and a wonderful discussion. Thanks a lot.
Thank you. Thank you very much. Bye-bye.
Discussions and the audience to join us in the next week. That is with another two beautiful webinars. Thank you. Till then, thanks a lot, sir. Once again, sir.
Thank you. Bye-bye. Thank you to all of you. Thank you for your time.